Every year, more than 600,000 women around the world hear a diagnosis that changes their lives: cervical cancer. Of these, over 340,000 die, mostly in low and middle-income nations. Behind these numbers lies an injustice, because today we know the main cause, the human papillomavirus, or HPV, and we also possess the means to prevent it. HPV is not merely a medical condition. It is a reflection of inequality, culture, and access. In poorer nations, where screening is rare and healthcare infrastructure fragile, the virus becomes a silent killer. Yet, it is a disease that science can now prevent with a simple vaccine. The global campaign against HPV is, therefore, more than a medical effort. It is a movement for justice. In countries like the United Kingdom, this movement has succeeded. Routine immunization and public awareness have transformed HPV from a threat into a vanishing disease. But across the world, in Pakistan, the journey is only beginning, facing obstacles rooted in culture, infrastructure, and trust. This is the story of two nations on opposite sides of the health spectrum. To understand the battle against HPV, we must begin with the virus itself. HPV, or human papillomavirus, is not a single virus but a family of over 200. Most types are harmless, but a few are deadly. Among them, HPV types 16 and 18 are responsible for about 70% of cervical cancer cases worldwide. In most people, the body's immune system clears the infection naturally within 2 years. But when it doesn't, the infection can linger, evolve into precancerous lesions, and eventually into invasive cancer. In countries with advanced health systems, regular screening, Pap smears or DNA testing catches it early. In others, where such access is limited, prevention depends entirely on vaccination. The vaccines, Gardasil, Cervarix, and the more recent Gardasil 9, are modern scientific breakthroughs. They protect against the most dangerous HPV strains and are proven to dramatically cut infection rates and cervical abnormalities when coverage is high. The World Health Organization recommends vaccinating girls between 9 and 14 years old, ideally before sexual debut. Many countries, including the UK, have also extended vaccination to boys to stop transmission and prevent male cancers. Over time, the results have been extraordinary. Countries like the UK, Australia, and Canada have seen drastic declines in HPV infections and related diseases, proving that elimination is possible. But to understand the power of prevention, we turn to the United Kingdom. In 2008, the UK became one of the first nations to launch a national HPV vaccination program. It was a bold move built on decades of public health infrastructure and trust in the National Health Service, the NHS. The vaccine was offered free to girls aged 12 and 13 through schools, with catch-up campaigns for older teens. Then, in 2019, the program expanded to include boys. It was a statement of equity and science, protecting everyone, not just girls. The results were historic. Within a decade, HPV infections among young women fell sharply. High-grade cervical abnormalities, once a common precursor to cancer, became rare. And now, evidence shows that among women vaccinated at age 12 or 13, cervical cancer has nearly disappeared. This is not a medical miracle. It is the power of planning, trust, and consistency. The UK's success stems from 4 pillars: strong infrastructure through the NHS, school-based delivery, removing access barriers, public trust built through transparency, and gender inclusion that protects entire communities. Of course, challenges existed. Misinformation about fertility or safety spread online, echoing global anti-vaccine conspiracies. The COVID-19 pandemic disrupted school sessions and slowed vaccine delivery. Yet the system proved resilient. Catch-up clinics, public reassurance, and trusted communication restored coverage and trust. From the classrooms of London to the clinics of Manchester, this program became a global benchmark, showing what is possible when science, trust, and governance work hand in hand. But halfway across the world, Pakistan's story unfolds very differently. Cervical cancer is among the leading cancers affecting women in Pakistan. Each year, thousands die needlessly, not because the disease is untreatable, but because it is unseen. The lack of screening, awareness, and stigma around reproductive health means most cases are detected too late. After years of discussion, pilot studies, and international advocacy, Pakistan finally took a decisive step in September 2025. For the first time, it introduced the HPV vaccine nationwide, targeting girls aged 9 to 14 in Punjab, Sindh, Kashmir, and the Islamabad Capital Territory. The goal was ambitious: 13 million girls in the first round and 17 to 18 million within 2 years. The campaign was supported by WHO, UNICEF, and Gavi, with nearly 50,000 health workers trained to make it happen. Within weeks, Pakistan achieved what many doubted possible: 9 million girls vaccinated. Over 70% of the initial target, despite skepticism, misinformation, and logistical hurdles. It was a moment of hope. The sight of Pakistan's health minister vaccinating his own daughter on live television became symbolic, an act of trust in science. But even as progress accelerated, the barriers remained complex. Cultural and religious sensitivities pose a major challenge. Because HPV is sexually transmitted, some parents fear that vaccination encourages immorality. Yet when religious scholars support it as a tool against cancer, acceptance rises. The message, therefore, is reframed, not about sex, but about saving lives and protecting daughters. Infrastructure presents another obstacle. Unlike the UK's integrated school health system, Pakistan relies on mobile teams, EPI clinics, and community drives. In cities like Karachi and Lahore, access is easier. But in remote villages, distance, limited cold chain storage, and fewer female vaccinators make coverage difficult. Then there's misinformation, an invisible epidemic. Myths about infertility or foreign conspiracies spread faster than the vaccine itself. To fight this, Pakistan's campaign turned to storytelling, radio shows, television discussions, and community gatherings. The vaccine was presented as a normal part of childhood health, like measles or polio immunization, not something controversial or foreign. And finally, the rural-urban divide remains persistent. Urban centers with NGOs and media outreach see high participation. In contrast, remote areas still struggle with staffing, transport, and mistrust. Mobile units and microplanning are slowly bridging the gap. Despite all this, Pakistan's government and partners have a clear strategy. After the first intensive campaign, HPV vaccination will be integrated into the expanded program on immunization, the EPI, becoming a routine vaccine for 9-year-old girls. If successful, Pakistan could vaccinate over 17 million girls by 2027. Yet sustaining this success depends on funding, planning, and most importantly, trust. When comparing the UK and Pakistan, the differences are striking, but so are the lessons. The UK's programme was built on a foundation of universal healthcare, clear communication, and predictable delivery. Pakistan's approach began as a campaign, fast, ambitious, and partner-supported. Sustainability will require turning that campaign into an institution. The UK uses schools as the main vaccination venue, ensuring equal access. Pakistan's hybrid model of schools and mobile teams has proven efficient for a rapid start, but to sustain success, a nationwide school-based structure will be essential. In terms of outcomes, the UK's coverage remains above 80%, with proven reductions in HPV infections and cervical cancers. Pakistan's 70% coverage within weeks is encouraging, but the true test will be consistency in the coming years. Public perception also differs. In the UK, trust in the NHS and regulated information protect against misinformation. In Pakistan, trust is built through community leaders, role models, and public storytelling. A reminder that health communication must be local to succeed. Gender inclusion is another frontier. While the UK vaccinates both boys and girls, Pakistan's campaign currently focuses on girls only. As the program stabilizes, policymakers may extend it to boys, strengthening herd immunity. And then there is financing. In the UK, vaccination is state-funded. In Pakistan, it relies on international support from Gavi, WHO, and UNICEF, a partnership that is vital now, but must transition to domestic funding for long-term resilience. So what can Pakistan learn from the UK? First, the power of institutionalizing school-based delivery. Second, the importance of evidence-led messaging that emphasizes cancer prevention, not morality. Third, the need for predictable, routine vaccination and regular catch-ups, making it part of normal health practice. Ultimately, the success of vaccination is not defined by needles, but by narratives. In the UK, HPV vaccination has always been framed as a fight against cancer, never as a debate about sexuality. Honest, factual, and compassionate communication built confidence. Parents consented not because they were told to, but because they understood. In Pakistan, the communication challenge is far greater. Social media myths can undo months of progress. Yet, the 2025 campaign showed the power of visible leadership and relatable storytelling. When a minister vaccinates his daughter, when imams deliver sermons supporting health, when teachers hand consent forms to parents, perception changes. Going forward, Pakistan's success depends on maintaining these narratives. In Urdu, in regional languages, through radio, television, mosques, and classrooms. Every conversation counts. Because in the end, vaccination is not just about saving lives. It is about shifting culture, dispelling fear, and restoring fairness. The global goal is clear: the elimination of cervical cancer as a public health threat. The United Kingdom has shown it is possible. Pakistan now has the opportunity to follow, adapt, and lead in its own way. For Pakistan, the next steps are vital. Integrating HPV vaccination into the national EPI schedule, empowering educators and religious figures as health advocates, and building financial independence to sustain supply and trust. If these steps succeed, Pakistan's daughters will inherit a safer future, one where cervical cancer becomes a disease of history, not destiny. The war on HPV is more than medical. It is moral. The vaccine is not just medicine, it is justice. And as the world edges closer to ending a cancer once thought inevitable, one message must echo from London to Lahore: no woman, anywhere, should die from a preventable disease.